Welcome. This presentation is on depression management. I'm Dr. Alka Agarwal. I'm an adjunct psychiatrist with Pine Rest Christian Mental Health, where I also provide collaborative care. Disclosures. The presenter and all planners of this education activity do not have a financial arrangement or affiliation with one or more organizations that could be perceived as a real or apparent conflict of interest in the context of the subject of the presentation. Our learning objectives for today are: we'll learn how to screen for depression, learn how to administer and score the PHQ-9, we'll learn differential diagnosis of depression, and so we'll start with the DSM-5 criteria for major depressive disorder. So to meet criteria for major depressive disorder, one needs to meet at least one of the following symptoms: either having a depressed mood or loss of interest or pleasure for more than half of the day. So that's more than half of the time. And then in addition to at least one of these symptoms for more than half of the time, one needs to also be experiencing 4 or more of the following symptoms, where they're experiencing it nearly every day for the past 2 weeks consistently. So that would include weight or appetite changes, either up or down, insomnia or sleeping too much, feeling really slowed down or lethargic, or the opposite of that, which would be feeling really agitated and restless. And some might express that as feeling like they're jumping out of their skin. They got to keep moving. Fatigue, feeling exhausted, even if they are sleeping or even oversleeping. Feeling worthless, hopeless, like their life has no meaning. And feeling guilty. So feeling like everything is their fault and they can't do anything right. Impaired cognition. Often people can have trouble with short-term memory. Difficulties making decisions are very common with depression as well. And then recurrent thoughts of death, dying, or suicide. And in another presentation, we'll talk more about suicide. But these thoughts could be anywhere from just passive thoughts of not wanting to be alive anymore, or just wanting to go away, or could be more explicit, thinking of specific ways how somebody might harm themselves or kill themselves. And these symptoms, the depressed mood, loss of interest and pleasure, and then the additional symptoms of depression, would be causing significant distress or impairment in their lives. So that would be in their personal lives, affecting their relationships, making it difficult for them to work. Maybe they've actually had their boss or supervisor or coworkers comment that they seem like they're not their usual self. They're not able to get as much work done as they need to. They're forgetting important things. So it is causing some distress or impairment. They might be working through that, but they are aware that they are not quite themselves. And there can't be another cause of major depression, and we'll talk a little bit about the differential diagnosis, because in other psychiatric illnesses, there can be depression, such as even in psychosis or bipolar disorder, or more mild forms of depression. Also, people can be experiencing grief and bereavement. It could be a side effect of a blood pressure medication that somebody's feeling sad or down, and that might not necessarily mean it's a major depressive episode. And you cannot have a history of mania or hypomania. If one does, they automatically do not have major depressive disorder, and they do have a bipolar disorder. And we're going to talk a little bit more in depth about this. But I say to take a good history, because bipolar can really disguise itself as major depression, because often people with bipolar will first present and maybe only present for many years with major depressive symptoms. And so if anybody has a history that sounds like it might be bipolar, they might have had some hypomania or even just one manic episode, then we want to really pay attention to that, because that then means they do not have a major depressive disorder, but they have a bipolar disorder. And then the DSM-5 criteria for persistent depressive disorder, what we formerly called dysthymia, is, I think, what people can call a more mild version of depression. It can still significantly cause disturbances in people's lives, socially and occupationally, personally. But the symptoms aren't as severe as major depression, but they are more chronic. So by that I mean somebody has had a depressed mood for most of the time, so nearly every day, for the last 2 years consistently. And that means without a break for longer than 2 months. So these people feel depressed most of the time, most of the days, consistently for 2 years, and there hasn't been a period of non-depression for longer than 2 months. And then while they're feeling depressed, there's also the presence of at least 2 of the following symptoms. Poor appetite, so they're not feeling as hungry, or they're overeating. There may or may not be weight loss. Insomnia or sleeping too much. Low energy or fatigue. Feeling bad about themselves, low self-esteem, feeling they're an ineffective person, feeling bad about themselves. And then decreased cognition can be, difficulty making decisions, planning, using executive functioning, and feelings of hopelessness, that things just aren't going to get better. So we talked about having never been without these symptoms for greater than 2 months, and that these symptoms do cause significant distress or impairment. So again, people are not functioning as well in their lives. They're not living life to the fullest. They're not living life to their full potential because they're being held back by these depressive symptoms. And there's no other cause. So there hasn't been a grief or bereavement. It's not part of a bipolar disorder or psychotic disorder. And then there's no history of mania or hypomania. And then we can ask, is this a double depression? So when people have major depression, they can also have dysthymia. So these often occur together. So what does that mean? That means that somebody can have a major depressive disorder where they have deep episodes of depression that can last anywhere from 2 weeks to several months or even several years. And then superimposed on that is a dysthymic depression or persistent depressive disorder. So somebody can have a deep depressive period, and then when that episode is over, say in 2 or 3 months, their mood doesn't quite go back to baseline. They don't go back to a neutral mood where they're feeling not depressed. They instead go back to this chronically depressed mood where they feel most of the time, where they still have poor appetite or overeating, not sleeping as well, low energy. It's not at the point of a major depressive episode, but they never quite get to a neutral mood. And in some senses, the dysthymic patients who have persistent depressive disorder can be more difficult to treat. This tends to be a harder type of depression to treat. So it's important for us to identify this and also let patients know that even though it's not as deep as a major depression, it is still depression and still needs to be treated. Because what can happen is when you have a persistent depressive disorder and it's not treated completely to the point where we aim for no depression at all, it can increase the risk for a major depressive episode. And then those episodes can become more frequent and more difficult to treat. So let's talk about depression screening. The United States Prevention Task Force recommends screening the general adult population. That means anyone 12 years and older. And we're probably working mostly with an 18 and older population, but if not, the PHQ-A for adolescents is the depression screening form that can be used. And this is for adolescents 11 to 17 years old. And some of the language is different from the PHQ-9, where instead of asking about work, the adolescents are asked about school activities. And the task force also recommends that we include pregnant and postpartum women. And as we know, these can be high-risk, vulnerable times for women for mood changes. And that adequate systems should be in place. And so having a care manager who can have frequent contacts with the patient and having a primary care provider who you can consult with. So you want to make sure when you're screening patients that you do have a process set in place for your clinic to continue to evaluate the patient, also to put in a treatment plan so that when you screen somebody and you do identify them as positive for depression, that there's a plan in place beyond that. So what's the optimal interval for screening? The task force doesn't recommend one. Um, it's not known at this time, but I would say to consider screening each patient every 2 weeks or every time that you see them. And that is because people's moods and their depression scores, as you'll see the more you do this, can go up and down based on what's going on in their lives. And what we want to do is look for an overall pattern. Are they getting better? Is our treatment plan effective or not? Or if you haven't started medications or the patient has declined them, it's a way to show them, well, 3 months ago we identified you as depressed based on the PHQ-9, and your score has gone consistently down. This would be a time that I would recommend medications or further treatment. So it can be helpful to have as many data points as we can get. And you can also use your clinical judgment for additional screening. You don't have to go by a specific guideline every 2 weeks. That doesn't need to be a rigid timeline. For example, if you're following somebody who's got very severe depression, you're thinking about hospitalizing them, you might want to do a screening, if you see them twice a week, or once a week, you might want to do the screening each time rather than waiting every 2 weeks. So the patient health questionnaire, the PHQ-9, is a 9-question questionnaire that you can administer to each of your patients, whether they have an established diagnosis of depression or not, because it's a screening questionnaire. So we're trying to find those patients who maybe have depression but haven't been identified or diagnosed as having depression. And this happens often when people learn to just live with their depression. They found ways around it, and so they never really thought that it was something they needed to treat. They may not have had a chance to talk with a mental health professional before, and so this might be their first connection with somebody identifying their depression. And so that's a pretty important step. And I would say to screen every single person that you see. If it's negative, then it's negative, and you might want to visit it at a later time. But you certainly don't want to miss somebody who has depression. And so the questions are pretty straightforward. They follow the DSM-5 criteria that we had talked about before. And there are 9 questions. There's actually 10 questions, 9 questions that are rated 0 to 3. And then the 10th question, the patient rates how difficult these symptoms have made their daily functioning of life and taking care of themselves, things at home or work or socially. So this is something you can give the patient and they can fill out, can take under 5 minutes. If they don't have any trouble reading the questions, there's no language barrier, and they're able to process the information. You can also help explain the questions to them if they have any questions. And then if you're meeting with patients over the phone, it's fine to ask them the questions over the phone. I do think something is lost over the phone, but it's better to do it than not do it at all. And so we talk about, little interest or pleasure in doing things, feeling down, depressed, or hopeless. And as we talked about in the DSM-5 criteria for depression, either 1 or 2 is necessary for a diagnosis of depression. Now, I just mentioned that because when we're interpreting the PHQ-9, it's interesting to see what the answers to questions 1 and 2 are. Somebody might mark 0 for both of them, and that maybe most of their issues are more physical. And that would be different than somebody marking, for example, nearly every day for questions 1 and 2. That would indicate a more deep, specifically depression. But it's also important not to try to diagnose somebody with the PHQ-9. This is a screening tool and not a diagnostic tool. You are the diagnostic tool. So you are going to put together with your clinical judgment and collateral information if this person meets criteria for major depression, dysthymia, bipolar, or other illnesses with depression. This is merely to screen to see if there is enough information or evidence there for us to dig further into a possible depressive disorder and what the treatment might be. So it's important not to take it too literally, and what we really look for is an overall score, and that is simplifying things a bit, but when somebody scores 10 or higher on this form, then we do want them to consider, have a conversation about treatment for depression. And that might be therapy, that might be medications, that might be further screening and collateral information, doing a differential diagnosis. But if somebody's scoring 10 or higher on the PHQ-9, then we definitely want to be addressing their depression. Doesn't necessarily mean they're meeting criteria for major depressive disorder or even dysthymia. It could be depression related to bipolar. It could be depression related to psychosis. But this is the first step in identifying at least that depression component. Some other important questions are looking at question number 9, thoughts that you would be better off dead or of hurting yourself in some way. We want to make sure every patient answers this question and doesn't skip it, and that we want to follow through with this question. Even if it's 0, say, so they say not at all and it's 0, you want to just double check and say, okay, you marked 0, not having any thoughts at all about death or dying, wanting to sleep and never wake up. You want to just make sure they understood that question properly. Some might think that question means, I'm absolutely going to go kill myself. You know, and if somebody's having some underlying passive thoughts of suicide, we definitely want to know that. And then question 10 is also of great importance because here's where we can get an idea of how much this is affecting their lives. Somebody might score, you know, 7 on the PHQ-9, so not quite 10, but they might say that things are extremely difficult. And we want to pay attention to that and say, okay, well, they haven't got a score of 10 or higher, but what is making things so extremely difficult in their lives? What is extremely difficult? Where are they getting stuck? What are they experiencing that made them go to the extreme, to choose the extreme option? And so, you know, take time and individualize each person's PHQ-9 and score and go through it with them. It's perfectly fine that they filled it out and just said, I'd like to just go through, make sure that your score resonates with truly how you're feeling. And they go through any questions that you're not sure of, or maybe you thought they were more depressed than they looked, or you're surprised by how depressed they are, or you're surprised by how much difficulty they're having, or how little difficulty they're having, and it's helpful to clarify that. And so how do we score the PHQ-9? Well, the PHQ-9 actually has a good true positive sensitivity and true negative specificity for major depressive disorder. So that means people who score greater than 10 on the PHQ-9 mostly do have major depressive disorder, and those who score less than 10 mostly do not have major depressive disorder. So it's a pretty good screening tool. But again, now I'll turn around and say, but we don't want to use it as a diagnostic tool. And so how do you score it? Well, so each of the 9 questions is rated 0, 1, 2, or 3. And that's the score that question will get. And you add up all of the scores of those questions from question 1 to 9. Question 10 does not have a score associated with it. So the lowest score is 0, the highest score is 27. 9 questions, the highest score is 3. They scored 3 on each of the 9 questions, they would have a 27. And then we look at the range. So 0 to 4 means they have none to minimal depression. Really, there's no action needed, except that we want to just keep an eye on things, especially if there's somebody who has had depression and has had higher PHQ scores in the past. We want to make sure that they stay in remission. And then 5 to 9, it's a mild depression. You want to be repeating the PHQ-9 at follow-up just to make sure that the score stays low. You might want to repeat it for 6 months and make sure it's below 10 for a total of 6 months. But again, you want to look at question 9 about suicide, and you want to look at question 10 about how much this is affecting their functioning. And then a score of 10 to 14 is a moderate depression, and that's why we use the score of 10 to cut off in terms of seriously considering treatment. We definitely, for anyone who has a score of 10 or higher, start putting together a treatment plan, therapy, and or medications. You will want to involve a mental health professional, psychiatrist, refer for psychiatry consult, or make sure the PCP is comfortable treating depression. If somebody scores 15 to 19, this is a moderate severe depression. You want to, most of these folks would likely benefit from being on medications. And then 20 to 27, this is the severe range. And I think a higher level of care is important here with a mental health professional, and then working with the primary care provider to see if a higher level of care is important, or what changes to the treatment plan you would want to make. So that means, do they need to see an urgent referral to a psychiatrist? Especially 20 to 27, you want to look at question 9, because you can't have 0 on question 9 at a score of 27. So you want to really look at how you would keep this patient safe, and if it's safe for them to be treated just as outpatient. And we'll talk more about that in depth in another presentation. So let's look at a sample PHQ-9 score to try to put this into practice. And as we've talked about, paying attention to questions 9 and 10, which are thoughts of death or dying, suicide, and then how impaired the person feels due to their depression. So, over the past 2 weeks, how often have you been bothered by any of the following problems? So, little interest or pleasure in doing things. This person has indicated that they have been bothered several days in the last 2 weeks. So they get a score of 1. And then feeling down, depressed, or hopeless, that's more than half of the days. So that's a score of 2. And as we can see for questions 1 and 2, when you think back to the DSM-5 criteria for major depression, they have to have either little interest or pleasure or feeling down or depressed for more than half of the days over the past 2 weeks. So looking at questions 1 and 2, this person would meet an initial criteria for depression. And that's just important to note, but that won't really be the final factor in your making a diagnosis. That's just helpful to note, I think. And then trouble falling asleep, sleeping too much. So they're having some severe trouble sleeping, feeling tired, having little energy, poor appetite, feeling bad about themselves. So, really looking at where this person is struggling. Trouble sleeping, feeling really bad about themselves, feeling down and depressed. They're having some appetite issues, and they might be having some weight issues. So that would be something you would want to check in with them about. And that's important when you're working with medically ill patients. Is that going to affect their diabetes medications, their insulin, their weight management efforts, and then trouble concentrating? So, how is this affecting their work? Do they feel safe when they're driving? If they're taking care of young children, do they feel like they can give them their full attention? Moving or speaking slowly, or being fidgety, that doesn't seem to be as prominent of an issue. And then question 9, thoughts that you would be better off dead or hurting yourself in some way. This person has experienced that more than half of the days in the last 2 weeks. That's a warning sign. And definitely a question that you're going to want to follow up with this patient on. How long have you been having these thoughts? What are the thoughts? And then thinking about their safety. And so how did we add it up? In the several days column, there were 3 questions where this person scored 1. So that's 1 plus 1 plus 1. That gives you 3. More than half days. 2 plus 2 plus 2 plus 2. That's 6. That's 8. And 3 plus 3, that's 6. So sorry, that should be 8. So this person has a total of 17, actually. And so, they're in the moderate severe range, and they're in the range where you want to be involving your PCP. You want to be involving a mental health professional. So that would be an urgent referral to a psychiatrist. And then you want to be looking at question 10, extremely difficult. So where is this person really getting stuck? Well, possibly because they're sleeping too much or not sleeping enough. They're feeling really bad about themselves, and that's maybe affecting social functioning or how they're functioning at work. So another sample is question 1 and 2. The person has marked 1, so that's several days. And then we think back to DSM-5, at least one of these would need to be more than half the days. So if we're looking at specifically in terms of diagnostic criteria, this person wouldn't necessarily meet criteria for major depression or dysthymia based on those 2 questions. But if you look at their score, it's 15. So that's in the range of concern. And I'm just kind of creating these examples just to highlight we can't take anything literally. We have to really look at the answer to each question individually and in context for this specific person, their specific struggles, and how they're experiencing depression. And also in light of question 9, because that will really trump any other answers anywhere. Even if they scored 0 on questions 1 to 8 and they had a score of 1 or greater on question 9, that's what we're going to focus on. And we would treat them as though they had a depression. So, I just want to really highlight that this is not a diagnostic tool, and we can't just say, oh, they have a score of 9. Okay, we don't need to worry about them. We want to really look at each question. And I will say, with psychiatry patients, nobody is zero risk. Nobody's at a 0 risk just by having depression, just by being in the collaborative care program. That means people do have some risk of safety. And so we want to really be careful about making sure we're screening everybody and not just making it a cutoff. And this is a change in the way we think about treating patients. Because if we look at blood pressure, we absolutely have a cutoff. We look at depression, diabetes, we absolutely have a cutoff score. And so, it would seem to follow that, well, great, PHQ-9 can be a cutoff score, but really, mental health doesn't work like that, and there's a lot of gray areas, and that means we can use the score of 10 as a rough guide, but really we want to dig deeper and understand what is making up that score of 10 and what are the other components involved with their depression. So what are the clinical uses of the PHQ-9? So screening and monitoring depression and suicide. So that means every single patient that you see, especially for the first time, absolutely should be screened with the PHQ-9. And then those with a score of 10 or higher, or if they, if in your clinical judgment feel like they need a higher level of care, they can be enrolled in the collaborative care program and receive weekly consultation with the psychiatrist. And then also monitoring depression. So, like we talked about, every time you see the patient, every patient contact, or if you're contacting by phone, administering the PHQ-9 by phone. And that way you can graph and follow the progress of the patient and the progress of your treatment plan. This can help hold us accountable. What we've prescribed in terms of treatment plans, that's community resources, therapy, could be ECT, medications. Is that helping? What's been the overall change in their PHQ-9 score? Like we talked about, it's not a diagnostic tool, so we can't say everybody with a score of 10 or higher or with a positive question 9 has depression. We don't quite know that, and we will need to do a differential diagnosis and use our clinical evaluation to really make that formal diagnosis. But it's good to be thinking about what the possibilities could be. It's nice to give a quantitative depression score, especially in collaborative care. We get the blood pressure reading, the cholesterol, lipid panel numbers, and their blood pressure. It can help to give the PHQ-9 score, but then in addition to that, explain what's making up that score. It can help us follow response and remission, so response to treatment plan and treatment interventions, have their symptoms gotten 50% better? What has happened to their PHQ-9 score since you've been working with them or since they were enrolled in collaborative care? And it allows patients and us as the providers to follow their progress. And it can drive treatment in that if somebody is scoring consistently 25, sure, we don't want to just use a score as a blind guide to treatment, but on the other hand, it's hard to deny how significant those symptoms are for that patient. And that question 9 response, so that's the question about death or dying suicide. Studies have shown that it does have a linear relationship to suicide risk. So that means the higher people score on question 9, the higher their risk for suicide is, for a suicide attempt or suicide completion. So that one question is pretty powerful in terms of our assessing our patient's risk and the seriousness of their depression. And validated uses of the PHQ-9, you as a clinician, as a care manager, can absolutely administer the PHQ-9 for your patient. So that means you can ask them the questions, ideally in person. If if they don't have their reading glasses or it's difficult for them to read the questions, the print is too small, or if it's over the phone, or you can hand it out to them, have them fill it out online, or before they see you, or during the session. And it's validated for use in over 30 different languages. So if you need the PHQ-9 in a different language, you should be able to find it, at least for 30 or more languages, of the more common languages. And then it's validated for people ages 13 and older, and even for elderly with mild cognitive impairment. So if you're working with an elderly population, 65 and older, who might have some, short-term memory issues, it is still a validated use in terms of screening for depression. And this is a patient population where you might want to administer it for them. And then in pregnancy and postpartum, where we know these are vulnerable times for women to have a depressive episode. So when the PHQ-9 is greater than 9, so for our purposes in collaborative care, in terms of registering or entering patients into the collaborative care program, we use 10 as a cutoff score. And that's because evidence has shown, as we saw on that slide, the true positive and true negative of PHQ-9 when the score is greater than 9 is pretty high, around 88%. And so we can feel fairly comfortable that if somebody has a score of 10 or higher, that they could benefit from more from a mental health professional providing consultation every week. Now, that doesn't mean just completely ignoring the patients that are below 10. They may not meet the criteria to enter collaborative care, but they still do need to have their PHQ-9 followed, and to discuss a treatment plan with them, especially looking at questions 9 and 10 and seeing where they are feeling most impaired. And maybe for 2 or 3 months, a patient might have a PHQ-9 of 7 or 8 or even 5, and then it might jump to 15, and that might stay up there for a while. So it's important to keep following the score. But for collaborative care purposes, where you will be registering your patients to join the weekly calls and weekly consultation, we are using a score of 10 as a cutoff. So when you have a patient who has scored 10, and you enter them into collaborative care and you want to present them and have them followed, there's important background information that you'll want to collect. So this is where we kind of start to gather more information about in what context is this person experiencing this level of depression. So you want to gather a history of present illness, and in this you want to ask about initially what symptoms they're experiencing, how often, what triggers them, in what situations they're feeling them more strongly, and in what situations are they not as aware of them, or what makes things better for them. And you want to really highlight currently what is the number 1 or 2 most troublesome symptom that you're having now, what's getting most in your way. Because it's a lot easier to try to target 1 or 2 symptoms, as you may have experience in primary care, versus trying to cover 10 different issues superficially. And then you want to ask about self-harm. This would be intentionally harming themselves, might be for the purpose of killing themselves, it might be just to relieve emotional stress or self-punishment, and this would be more often by cutting with razors or scissors or other sharp objects, burning themselves, hitting their head really hard against the wall, choking themselves, suffocating themselves, partially drowning themselves when they're in the tub to the point where they feel like they're going to die and then lift their head up. Again, might not be in a suicide attempt. It might be for other reasons, and it's important to understand those reasons and the triggers for that self-harm. And then you always want to do a suicide risk. So that's the question 9. Building on question 9, even if it's negative, even if they mark 0 on question 9, you want to just double check. No thoughts of death or dying, wanting to go to sleep and never wake up, leaving this world and not having to come back. If they say, well, sometimes I feel like if I got hit by a car and I died, that'd be okay. You want to ask about other thoughts. When did these thoughts start? How often do they occur? Is there any intention to act on these thoughts? Have they done anything to start the process to act on these thoughts? Giving away things, collecting medications to overdose on, driving by a bridge just to check it out and see what kind of access they would have to it. And then is there a specific plan on how they would act on these thoughts? And then you want to do kind of a past psychiatric history, and you want to screen for other psychiatric disorders that they might have now or they might have had in the past. So generalized anxiety, and there is a screening tool for generalized anxiety disorder, GAD. It's the GAD-7. There's 7 questions. It works similarly to the PHQ-9. And you can also use a score of 10 or higher on the GAD-7 to really gauge if somebody is warranting treatment or further follow-up for their anxiety. So anybody having panic attacks, compulsions or obsessions, to screen for OCD? Do they have a history of trauma or abuse, PTSD with nightmares, re-experiencing, any disordered eating, restricting severely their calories during the day to less than 1,000 or lower, or binging and purging? Or is there a binging disorder where they're eating so much to the point where their stomach hurts or they feel sick? And then you want to screen for psychosis, auditory visual hallucinations, paranoid thoughts. And that can just be a quick question. Do you ever have any periods where you're not sure what's real or what isn't? You feel people might be trying to harm you or follow you. You see things other people don't see. You hear things other people don't hear, or you hear voices when you're by yourself. And then you'll always want to do a substance use screening, which I'm sure most of you are already doing in primary care, screening for alcohol use, any drug use, tobacco, and then narcotic pain medications. And the reason we screen for these is that they can affect depression. They feed into depression. Depression feeds into them. Panic attacks, PTSD, trauma, psychosis, and substance use all increase risks for suicide as well and affect people's judgment. So these are important disorders to follow, and also to make sure we treat effectively. And then going more back into the past psychiatric history, do they have any history of inpatient psychiatric hospitalizations? Who are the previous psychiatrists they've worked with? Or another really important question is previous medications that they've been on. So that would be all of the medications that they can remember they've been on, when they were on them and for how long, and what the effect was. Was there a therapeutic effect or not? Did they have side effects, and if so, which side effects? And why was the medication stopped? This will really help clarify a lot. One, it'll help you understand what their experience in the mental health system has been, or what their experience with psychiatry medications have been if they haven't seen a psychiatrist before. It'll help you also understand what options you have in terms of choosing medications, what medication class they've responded best to. It might elucidate some information about bipolar, which we'll talk about later. And also, if they've had a true trial on an antidepressant, they might say, oh, I've tried every SSRI out there, none of them work for me. And then you might ask more about their medication trials and learn that they took Prozac, Paxil, Celexa, Lexapro each for just 2 or 3 days and stopped because of side effects. That wouldn't be a true trial. A true trial would be 4 to 6 weeks on the medication. And maybe the dose was too high. Maybe they're a slow metabolizer, and maybe they need half the dose that the average population can tolerate. So you can learn a lot by looking at what the past medications were and digging a little deeper. It can feel tedious at the time, but it can be really helpful to understand more about what their path has been with psychiatric medications. I think it can also help us understand our patients more as human beings and what kind of experience they've had. And if they're feeling discouraged, this might help us understand, yeah, wow, you've been tried on a lot of medications. I can understand why you're feeling frustrated, or maybe that, why you think the medicine wouldn't work, or why you're reluctant to try medications. So it can help us understand them more fully. And then what's their experience with therapy? Have they ever done therapy before? If so, what kind of therapy? Was it CBT? Was it DBT? For how long? And what was their experience? I've had some patients who say, I hate talking to people. I haven't liked any of my therapists. I won't do therapy. So that's helpful to know. And, we want to respect our patients' wishes and experiences. I think it's also a really rich kind of area to look into, well, why is that? Helps us understand a little bit more about our patients. Why might they have had such a bad experience? And that might, if we can talk about that a little bit more, that might open them up to another type of treatment. So in addition to the medications, is there a type of therapy or a type of therapist that they would work better with? Because I think it's pretty hard to treat depression without concurrent therapy or some type of group therapy. And then their history of suicide attempts, how many, what ages, what was the situation, did they get medical care, were they hospitalized, what was the trigger? Same with self-harm, and the last time they self-harmed, and then a history of abuse and trauma. And this is important because it can help inform how we interact with the patient. We can be more cognizant of how we interact with them, where we sit, how we sit, the volume of our voice, the language that we use, if we're male or female, and how this patient might react to our gender, and can also really point us to higher risk factors for the depression not getting better, higher risk factors for self-harm or suicide attempts, and can also drive the treatment plan. Would group therapy be a good idea or not? What type of therapy would be most helpful for this person? Substance use history, very important. So we asked on the last slide, we asked about current substance use, but what about in the past? Had they ever had any trouble trying to cut down alcohol, any drugs, tobacco, nicotine, narcotic pain meds, or other prescription pain medications? And if so, have they ever been to detox or rehab? When was that? For what substance? Do they have any cravings currently for those? What's their caffeine intake? Very important for patients who are coming in with panic attacks and anxiety. Once we start getting above 2 or 3 caffeinated drinks a day, that can really start to affect people's anxiety. And for some people who are sensitive, even 1 cup of coffee affects their anxiety and panic, but they're maybe not aware of that because they've been drinking coffee for years. And then it's helpful to know about legal issues related to substance use. This can help us understand the severity of their substance use disorder. Any DUIs or driving under the influence, have they had any arrests? Are they on probation? To what point has their substance use been an issue for them? And then we also want to get a family history. So any family history of psychiatric illness, depression, or anxiety, and if so, what medications those family members have been on. First-degree family members, may share the same response to psychiatric medication. So if somebody's mom or dad has done really well on Prozac, that might be the medication option for this patient, depending on kind of what their symptoms are and if that's clinically indicated for them. They might also have the same side effects to the medications and may want to just avoid certain ones that their family members haven't done well on. And then any family history of bipolar disorder. That's very important because bipolar is genetic, and 10 to 15% chance if one biological parent has bipolar that a child can have it. And so we really want to be looking out for family history. This is particularly important when we're not sure of the diagnosis. We're not sure if somebody has bipolar or not. And we have some kind of vague clues. Family history can just kind of help tilt our diagnosis one way or another. And then any family history of attempted or completed suicide. So patients who have a family member, first-degree family member who has committed suicide have 6 times the risk of suicide than the average population who does not have that family history. So very important, and that will also help drive your suicide assessment risk. And then social history, you want to understand what their living situation is, how stable or unstable that is, the relationships they have in their life, so that's what type of social support they have, what their highest education level is and their employment status, physical activity level, are they exercising at all, stressors and responsibilities that can help us understand, when we're trying to say, well, why can't you just go walking for an hour a day? Well, they've got a lot of stuff going on, and how can we help fit that into their daily life? What are their coping skills like? When things haven't gone well in the past, how have they coped? And do they have any hobbies or healthy adaptive distractions? Any pending legal issues and military experience. That's important. It helps us understand if they have any other healthcare resources, maybe through the VA, but also veterans have a higher risk for suicide. And so that helps us also assess risk. So very important also, once you've gathered all of that information, is you really want to start narrowing down your differential diagnosis. So you want to start screening initially for bipolar. This is going to be every single patient, whether you think it's a slam dunk major depression or not. Even if they said, I don't have bipolar, I'm not manic depressive, no one in my family is bipolar, I don't have that. You want to still do your own screen. You don't want to rely on past diagnoses. A lot of people come with a diagnosis of bipolar for years, and that might not be the right diagnosis, or they never got diagnosed. Bipolar often presents primarily as depression. And the danger here is that if it's treated with an antidepressant, and when I say with an unopposed antidepressant, I mean they're on an antidepressant without a mood stabilizer, so they're just on Prozac, as opposed to being on Prozac and lithium and Abilify, something that will stabilize their mood. It increases their risk for suicide, mania or hypomania, and it won't treat their depression, and in fact could worsen it. So very dangerous to be prescribing an antidepressant to someone who you haven't done a bipolar screen on. Patients with bipolar attempt suicide twice as much as a patient with unipolar depression. 15% of bipolar patients commit suicide, and 80% have considered suicide. So we really don't want to be missing these patients. And so you want to assess their current symptoms. And then we want to screen for a history of hypomania or mania. Hypomania is a less severe form of mania. A good diagnostic tool is the CIDI, the Composite International Diagnostic Interview, which I'll show you on the next slide, which really helps elucidate the questions for bipolar based on the DSM-5 criteria for bipolar. And I think that the CIDI words those questions in a way that most people can understand and distinguishes them from other similar illnesses like anxiety or borderline personality. Always want to ask about family history, and I recommend talking to a family member. It can be a partner or spouse or a first-degree family member about how has this person presented in the past. Have they ever had any periods of higher energy? You can go down the questions of the CIDI, any other questions or concerns that the family members have had about their mood, any hospitalizations or other treatment that the patient maybe doesn't remember, especially as a child. Very, very important. And then this goes back to that question where we ask about their response to medications. In the past, if they tried Prozac, how did they respond? Did they feel more hyper and had trouble sleeping, and maybe didn't sleep for 3 or 4 nights, just felt like they didn't need to? That would be a very typical bipolar response to an antidepressant. And then you want to screen for some common comorbidities. Migraines, anxiety, substance use, obesity, binge eating, ADHD can often go along with bipolar. So you always want to be screening for comorbidities. And then the specific screen for hypomania, you want to ask about a distinct period of time in the patient's life that lasted for at least 2 to 3 days consistently. So we're not talking about my mood is up from 1 minute to the next, my mood changes, I'm moody. We're not talking about that. We're talking about their mood being a consistent mood for 2 to 3 days, where they could be irritable or elated. They don't have good judgment. They feel like everything's going to be okay. They're not worried about things as much. They can get into arguments with strangers. They can become violent. They can have an inflated sense of self or grandiosity. They think they're better than other people. They think they can take on more than they normally can. It's not that they can't sleep. So they might say, oh yeah, I've had 2 or 3 days where I just couldn't get to sleep and I felt more hyper. That's not necessarily bipolar, because in bipolar, people just aren't concerned with sleep. They just simply don't need it. So it's not like they're trying to sleep or can't sleep. They're not bothered by it because they're so focused on other things. Talk fast, they talk a lot, they talk about things that maybe aren't important, they talk really loud, and they can be really hard to interrupt. And you'll notice that in your office with them, that you'll have to keep interrupting them. They can have flight of ideas or racing thoughts, so that means they jump from topic to topic. You might ask them about how their sleep has been, and somehow they've gone to how they're buying a new car. And they haven't answered your question, and they've jumped from topic to topic to topic. And they feel like their thoughts are going very fast. When you ask about racing thoughts, that can be hard because in anxiety, people feel like they can't shut their mind off. And so racing thoughts would be lots of ideas, lots of creativity. You're focused on doing a lot of different things rather than ruminating, worrying, feeling doubtful. That would be more anxiety. Bipolar is not a crisis of self-esteem or confidence. That's more, I would say, indicative of anxiety. And then people can feel more distractible. So again, that's also common in anxiety and ADHD. But they can find it hard to focus on things. You might notice that in your office, they're very distractible and it's hard to get them to process what you're saying. Lots of goal-directed activity or agitation, so that means they're really focused on certain activities. For example, staying up really late and cleaning for hours instead of going to sleep. And then excessive involvement in activities with a high potential for painful consequences. So this wouldn't be staying up late and cleaning because there isn't necessarily a high potential for bad consequences, but spending lots of money. For example, buying a new car, a $40,000 new car, they don't have the money, they don't need the car. Sexual indiscretions, so more sexually active with people who they don't know, unsafe sex, especially if they're in a committed relationship and this is not usual for them. Planning last-minute trips that could be very expensive or dangerous, traveling alone. And very common is increased use of substances, alcohol and drug use, either increased from what they currently use or using them when usually they don't. And then in mania, you can have psychotic symptoms. So that means auditory visual hallucinations or delusions, feeling like people can take thoughts out of their mind or they can put thoughts in other people's minds. The TV, radio are sending them special messages. If somebody has any psychotic symptoms, they automatically have bipolar 1. That's automatically manic and the more severe form of bipolar. Hypomania or bipolar 2 does not include psychotic symptoms. And it can be any theme. In my experience, I've noticed a common theme is talking to God or God talking to them, fighting demons, some of these other types of delusions. And so here's the CIDI that you can use to screen for hypomania. And I would just keep a copy of this in your office. And you can ask, you can say, some people have periods lasting several days when they feel much more excited and full of energy than usual. Their minds go too fast, they talk a lot, they're very restless, they're unable to sit still. And sometimes they do things that are unusual for them, like they can drive too fast or spend too much money. Have you ever had a period like this, lasting several days or longer? So it's worded very nicely, and you don't have to come up with your own questions. You don't have to reinvent the wheel here. You can just go down these 12 questions. So you can ask about the euphoria, you can ask about the irritability, that's question 2, and then question 3, you can kind of screen for these more episodes in terms of change in thinking and behavior. And then you can go down and ask all the specific criteria. So these are the DSM-5 criteria: irritability, restlessness, sleep, spending more money, things like that. And this is a screening tool that has good reliability. And so, I would keep a copy of this handy and I would run through it with each patient, at least at each initial meeting with the patient. And then this is kind of a busy slide, and we don't need to get too into detail about it. What I wanted to do was just show you that bipolar is not a distinct illness where it's as easy to say somebody meets the criteria or they don't, because there is a bipolar spectrum. And so, sometimes we might say, oh, we're all somewhere on the OCD spectrum, right? Especially as mental health professionals or as clinicians. We have attention to detail and we like things a certain way. We follow algorithms and processes and policies. And so, we might be more concerned with orderliness, organization, tidiness than maybe, the average person. So we're somewhere on the OCD spectrum, but we're not necessarily meeting criteria for OCD. And that is the same for bipolar spectrum, where, on one end of the spectrum, there's the true unipolar depression. And then on the other end, where it's red, it's the true full-blown mania with psychosis. But there's an in-between. As we know, as you move down to the left from mania, there's mania with subsyndromal depression. There's then a mixed state where you can have depression and mania. And then there's depression with subsyndromal hypomania. So that means depression with some hypomanic symptoms, or you can have mania with some depressive symptoms. You don't need to keep track of all of this, and you certainly don't need to be diagnosing any of this. This would be more at the psychiatrist level. But what's important to understand is that you can have patients who are bipolar-ish. So that means they're somewhere on the bipolar spectrum. They might not be meeting criteria for bipolar 2. They might not be meeting criteria for hypomania, but you have some suspicion that they maybe have family history bipolar, and they've maybe described an episode that was maybe 1 or 2 days versus 2 or 3 days where they were heightened energy and didn't need to sleep as much. And so, but they've done well on antidepressants, but their depression still hasn't gotten better. So there's some conflicting information. They might be somewhere in the middle. And the reason why I do bring this up is that because if patients do have some element of bipolar, they have a much worse prognosis than unipolar depression. So any aspect of bipolar does complicate the picture, even if they don't meet full criteria for hypomania or bipolar 2. And then I want to talk about differential diagnosis, because I think as we're talking about bipolar and depression, it's really important to think about and do an initial screen for other illnesses that can look like major depression. And so for the diagnosis of major depression, some of the key questions you want to ask is, does the patient have a history of mania or hypomania? Is the patient experiencing manic symptoms like distractibility or racing thoughts during their depressive episode? Age of onset of depression, if the earlier the age of onset, the more risk for bipolar. And what's the patient's prior response to antidepressant medications? If they felt activated on them, they didn't work, they had trouble sleeping, that could be indicative of bipolar. And so looking to the rightmost column, we can see onset before age of 18 is more suggestive of bipolar, manic symptoms, of course, hypomania, prior adverse response to antidepressant medications, racing thoughts, irritability, suicidal thoughts are suggestive of bipolar. And then I think one of the harder disorders to distinguish from bipolar can be borderline personality disorder. And that's because both are sort of moody symptoms, both have emotion dysregulation involved, and risky behaviors, self-harm, suicidal thoughts. So it can be hard to tell the two apart. I would say, at the risk of oversimplifying it, I think borderline personality is more about emotion dysregulation in shorter duration. So more moodiness, up and down in mood from 1 minute to the next, from 1 hour to the next, versus a consistent mood for 2 or 3 days at a time. Also in borderline personality disorder, sleep, there may be no decreased need for sleep. Their sleep needs might be the same. There might not be the euphoria, there might not be changes in self-esteem or self-confidence, but they can share impulsivity and risky behaviors. So I think one of the main questions is, how long do these hypomanic manic symptoms last for? If it's days if it's minutes to hours, it's unlikely bipolar. And if it's happening in an inconsistent pattern, so one day to the next is different, that's also more indicative of borderline personality. Generalized anxiety, does a patient have an inability to control worry? So this is more worry, fear, anxiety, self-doubt. Usually in bipolar, that's not as prominent, or if it is, there's more of an element of like anger. They'll be more intense. They'll be more like a stronger mood. They might want revenge, or they might feel more activated by it, versus generalized anxiety, they might just feel more tense and more exhausted and more anxious. PTSD, so you want to ask about if the patient has experienced a traumatic event, any symptoms of re-experiencing like flashbacks, avoiding thinking about it or avoiding the scene of the crime, or nightmares, easily agitated or startled. So if their mood changes are related to re-experiencing these traumatic events, or more like nightmares or flashbacks, that's less likely to be bipolar or more likely to be PTSD. One thing with PTSD is people can experience psychotic symptoms, and so that could be confusing. So you want to just really look at what are the psychotic symptoms, what are the emotions related to, are they related to this traumatic event that the person has experienced. And then substance use disorders, very important to get a history for this. Do they use substances? How often? Often used in conjunction with bipolar. The diagnosis, depression, mania, hypomania or not, can be very difficult to make when substances are on board. And I tend not to make a definite diagnosis until the person has been completely sober off any substances for a month. Of course, caffeine and tobacco are okay in terms of making the diagnosis, but alcohol, any drug use, prescription pain medications, they need to be sober off of those for 1 month consistently before you can really make a definitive diagnosis. Other things to think about: schizoaffective disorder, which is a combination of bipolar and schizophrenia. To simplify that, schizophrenia, traumatic brain injury. So this is also important when you take a medical history, asking about head injuries, loss of consciousness, concussions, ADHD, panic disorder, and impulse control disorders, which can look a lot like borderline personality as well. You want to think about a higher level of care. If the patient has a suicidal intent or plan, or self-harm, if they've been violent, risky behaviors that can increase their risk for STIs, getting arrested, being shot by a police officer because they've provoked them or been aggressive towards authority figures, driving recklessly, concerns about their safety at work, if they're a clinician or in clinical work, operating heavy machinery, driving, working with clients or young children, and then if they have psychosis, especially command auditory hallucinations, which can often tell them to harm themselves or somebody else, or can tell them this person is very dangerous, and so they feel like they need to protect themselves. And concurrent substance use disorder, all of these things can severely impact somebody's or impair their judgment and increase their risk for self-harm or harm to others. Weight loss, severe sleep deprivation as well, and they can also affect their concurrent medical illnesses as well. And so higher level of care means urgent referral to psychiatry, certainly wanting them to be in collaborative care. Do you think they need to be hospitalized? And consulting with your PCP and your team about hospitalization, and at least making that offer to the patient. They may not warrant involuntary hospitalization, but offering to facilitate a voluntary hospitalization. Can they get into an intensive outpatient treatment program? And especially agitation, irritability, and anger do increase people's risk as well. If you feel, if they're on multiple medications, especially like lithium and Depakote, and then several antidepressants, and that also Abilify, and then benzo to sleep, and their medication regimen is getting very complicated, that's definitely a time that you want to be referring a patient for psychiatry consultation. And if you've been making medication changes and the patient hasn't improved, and you're worried about their safety or their PHQ-9 is going higher and higher, you definitely want to refer. And then we talk about medical assessment. These are things you can do in your office before they get in to see psychiatry, or anytime you feel that it's indicated. But a urine tox screen can be very helpful, especially if you're not sure what the diagnosis is, and you think substance use is playing a part in it. Pregnancy tests for all female patients, especially if they're going to be on psychiatry medications, because they do have effects on the baby in pregnancy. And really talking to your patients about long-term reversible contraception, long-acting reversible contraception. So an IUD or implant can be very helpful. It's not something they don't have to remember every day, and then we can prevent these unplanned pregnancies while they're taking psychiatric medications. And then you want to also make sure you know what their drug levels are. So you want to know what their lithium level, Depakote level, Tegretol level is, and then any labs that might go along with that as well, like liver function, white blood cell count, their chemistries, their thyroid, fasting blood sugar, especially if they have diabetes. That could be a reason why they're maybe appearing psychotic or their mood is unstable. And with the drug levels, you want to make sure they're not toxic, especially with lithium, where there is a narrow therapeutic window for toxicity. And then in terms of more screening, thyroid, vitamin B12, folate, vitamin D, and then STI testing, including HIV, especially for those who have not practiced in safe sex. And so looking at what our treatment goals for the PHQ-9 are, we really want to aim for, initially clinical improvement. That means getting their PHQ-9 to a score of less than 10, or PHQ-9 score less than 50% of their baseline score. So that means you've gotten them down to half of what their score was. So if their score was 10, you want to get them to 5 or less. And then remission would be no depressive symptoms. That would be PHQ-9 score of 5 or less. Remission is 6 months or longer. And you want to continue to monitor them during the 6-month period till they get to that 6 months to make sure that they are in remission. So just a short word about PHQ-2. This is a screening tool that you can use if you feel your practice is too busy and you don't have time to administer the PHQ-9 to every patient. The caveat here is that PHQ-9 is only a screening tool. It cannot be used to monitor someone. And so if you give someone a PHQ-2 and they score 2 or higher, you have to give them the PHQ-9 anyway, and then you can no longer use the PHQ-2. So it's a one-time deal for patients you meet for the first time. And so really, I would recommend just going ahead and giving them the PHQ-9. And then in terms of creating a treatment plan, that's going to be driven by kind of following their PHQ-9, like we talked about. That can be every visit or every 2 weeks. And then, graphing and following the scores of the PHQ-9 with the patients can be really helpful for both of you in terms of following their progress. Setting concrete treatment goals with the patient, what would they like to be able to do versus how they'd like to feel, can be really helpful in terms of tracking your progress with their treatment goal. And then ideally you would treat for 12 months after the PHQ-9 is less than 5. So from the day that they're starting to feel good, from the day that they feel their depression is gone, you want to treat them with the same medication for 12 months. That helps prevent the depression from coming back. And then in general, in terms of treatment, my practice is if I start a new medication, I see people back in 2 weeks just to check in about side effects and how they're tolerating the medication. You also don't want too much time to go by if you've prescribed the wrong medication. You didn't pick up on a bipolar, and you don't want them being hypomanic for a month at a time. You really don't want them to be hypomanic even for 2 weeks, but that shortens that risk period. And then ideally, I'd like them to have followed up with a therapist weekly, so that really every week they have some type of clinical contact with someone. And then if we've made medical dose adjustments, then we can follow up in 4 weeks. And really a big part of your role is to problem solve with patients to make sure that they can take their medications daily. Is that reminders? Is it writing it down? Attaching it to another habit? Right when you brush your teeth, you go and take your pill right away. Whatever it is, because the medications don't work as well if they're not taken consistently. And then this is an ongoing process to continue to assess for bipolar, affective dysregulation, borderline personality, PTSD, ADHD. Of course, you're not going to be able to screen for all of this in the first session, but I would say in the first session, it's important to do the PHQ-9, do the CIDI bipolar screen, and do a safety assessment for suicide. Those are the keys. And then if you can slip in there substance use, current substance use, those are the keys for the first visit. And then you can fill in information after that. And then you also want to be assessing for and treating comorbid illnesses. You know, there might be more information that comes along as you get to know your patients about that might be more supportive of bipolar. And then you want to use evidence-based therapy. And in a different talk, we'll talk about behavioral activation, problem-solving therapy, in terms of therapies we know help with depression. And then it's also part of your role to provide psychoeducation about the medications, side effects, and the course of illness, so they know what to expect with their treatment plan, and they don't get discouraged and end up stopping the medications without talking with you. And then certainly want to consult with the psychiatrist as needed, sending referrals, or enrolling your patients in the weekly case consultation. And so providing psychoeducation for your patients, you know, really you want to help explain what is depression, you know, help connect their physical symptoms to their mental health. And, you know, questions like what is depression, that can often be part of, you know, a handout of information that you can print out on UpToDate or another website resource. So again, that's not something you have to reinvent and create for yourself, but you can help explain to them that it's like any other medical illness. It's like diabetes, it's a chronic illness. There's no cure, but you can treat it with lifestyle changes, and also sometimes people need medications. And, you know, using colloquial language, so making sure they understand what you mean and moving away from more medical terminology. And assessing for stigma concerns. Is this part of somebody's culture where they see mental health as a weakness? Has somebody in their family or themselves had a negative experience with depression or treatment? Trying to normalize it. You know, you have a lot going on, and sometimes we all need some help. And you know, there's probably some genetic contribution to your depression, and been triggered by a lot that's going on. And, you know, we're not talking about taking the medications forever, but for now it looks like you could use some help, and the medication can help you get to a point where then you can start to take over with your coping skills. But right now I think the depression is pretty deep, where the medication can help just get you out of that deep depression to the point where you can start using therapy and exercise and diet changes to take you the rest of the way with the depression. And making sure we commend and problem solve with our patients as well. You know, if they're not getting better, they're not taking their medications, or they skipped appointments, you know, instead of reprimanding them, we can say, okay, well, what did we miss here? You know, we obviously missed something in creating this plan for you, so let's go back and look at what might work better for you next time. And then letting them know about side effects of medications, and that they are temporary, and that the side effects are short-lived, but the therapeutic effects take a little bit longer to kick in. And to call you before they're going to stop the medication. Maybe you can just talk about it on the phone as well. And then making sure you leave time for questions, or letting them know how to reach you if they have questions after the session. And then I'm not going to read all of this in detail, but just some thoughts. about depression. It's not the blues. It's not something you can snap out of or will your way out of. It's not a weakness. It's a medical illness. There's a family history genetic component to it. You know, it's due to some chemical changes in your brain. We don't know exactly why. It has something to do with serotonin, dopamine, norepinephrine. You know, more and more we're thinking it has to do with inflammation, and that's why inflammatory illnesses like stress and diabetes and obesity can affect depression as well. You can have physical symptoms of the depression, and it's not curable, but it is treatable. And there's lots of different parts of the treatment plan that can be helpful, including medications. The cycle of depression, you know, if we don't do anything about depression, we feel more depressed, and then we withdraw. The more withdrawn we are, the less we do, the more depressed we get, and so the cycle continues. And so where do you and your patient feel like you can break that cycle together and push through the difficulty to break the cycle? And then just talking about the effects of antidepressants early on in the first week or two is when they're really going to feel the side effects, and then they should taper off. And then the therapeutic effects start around 3 weeks or so, and then really have their full effect at 4 to 6 weeks. And then, you know, maybe giving them a handout on, you know, how to manage side effects and what are some of the common ones: headache, stomachache, dizziness, nausea, diarrhea, constipation, feeling too tired or feeling, you know, sleepy, weight gain, sexual side effects. And you always want to mention, you know, that these side effects should go away in the first week or two, but it's going to depend on, you know, what they can tolerate. I often suggest taking them at bedtime or right before they go to sleep. So if they're feeling tired or sleepy or dizzy, it won't impact their day-to-day functioning, especially driving or while they're at work. You don't want people falling asleep at work. And then for the case consultation, when you're presenting a patient with depression to the psychiatrist, you know, some important things you want to have ready to talk about, even on the first presentation of the patient, are some demographic background information, like 45-year-old married Caucasian female with major depression, most recent PHQ-9 score and how that's changed from the last. What was question 9 on the PHQ-9? Is there any suicidal ideation, intent, or plan? Life stressors or behaviors for the patient that you're concerned with. So what are their concerns, but also what are your concerns? What are the CIDI bipolar screen results? You know, including family history, any collateral information that you might have gotten, what were their past response to psychiatric medications? What is your working diagnosis and or differential diagnosis, and what would you like help clarifying? And then really, what is the patient most concerned with right now? What are their current medications, doses, when were they last adjusted, the side effects? How does the patient feel like the medications are working? And what are the past psychiatry hospitalizations, past suicide attempts, or self-harm? And then, like we talked about, you know, detailed information about the past medications that they've been on. And then current and past substance use issues, family history of bipolar or suicide attempts. So really just a summary of, you know, all of the background information that we had talked about. And as questions start to come up, you know, you can kind of review the webinar, you know, and then we will have an opportunity to address questions at a later time, but maybe writing down some of the questions that come up for you, discussing them with each other, and really writing down for yourself where in any of this treatment plan or assessment or screening or monitoring you still have questions for yourself, you still don't feel comfortable, or you're still concerned about. And that's the end of our presentation. Thank you.
We'd like to thank you for attending today, and we welcome you to watch the other webinars in this series. They can be found on our website at www.mi-CCSI.org and click on upcoming events. Thank you.